Thank you for inviting me. My name is Olarinmoye, as has been said. The title of my presentation is One Health Action in Rabies Eradication, a Research Veterinarian's Perspective. And the outline is as shown. I'll be talking just briefly on what the definition of rabies is, a brief history of the animal and human form of the disease in Nigeria. I'll also be talking about the various routes and cycles of rabies transmission, even as it exists here in Nigeria, because that is the focus of our attention today, the control of rabies here in Nigeria. Number two, I'll be talking about one health action in rabies eradication. Much of what needs to be said has been said by the first presenter, so I will only be adding a bit more to that from the research veterinarian's perspective. I would also be describing what are the gaps, because those gaps will determine the future trajectories of research here in Nigeria. Now the introduction. What is rabies? It is an acute, progressive, and highly fatal viral encephalomyelitis of all mammals, all warm-blooded animals, and it is the deadliest of all known zoonoses, with a case fatality rate of greater than 99.9%. That is according to Manoj et al. 2016. Now, to facilitate and standardize rabies diagnosis globally, especially in resource-scarce regions, where laboratories for definitive diagnosis are non-existent or few and overstretched, the WHO has coined case definitions of the human disease based on exposure history and typical clinical signs of disease manifested by its victims, both human and animals. Now, regarding the clinical case, according to the WHO, a clinical rabies case is one in which the affected individual, animal or human, exhibits signs of encephalitis characterized by hyperactivity or paralysis, coma, and death due to respiratory failure, especially within 7 to 10 days of the onset of such signs. A suspected case of rabies is one that matches the definition of the clinical case without evidence of exposure or contact with a suspected rabid animal. In other words, you have a person or dog or animal of whatever, a mammal, that is showing the clinical signs of rabies, but there is no evidence of contact. Nobody can say, oh, there was a contact between this person or this animal and another rabid animal. In that case, the WHO has characterized such categories of rabies cases as suspected cases. Now, a probable case, as the name infers, is a suspected case with evidence of exposure or contact with a suspected rabid animal. And a confirmed case of rabies is a suspected or probable case of the disease that is backed up with a positive laboratory test result. These classifications had come up as far back as 2004 by the World Health Organization. And this has guided rabies diagnosis in many climes, many countries in the developing world. This was the situation I encountered in Liberia in 2015 when I went there for my research, and I discovered that before my arrival there, in spite of the fact that the WHO and many other world health bodies had been involved in treatments and in health interventions in Liberia, nobody had prior to that time deemed it fit to apprehend the culprit, I would like to say. Nobody had characterized and definitively diagnosed the etiology of rabies in that country. This is the situation in many parts of Africa, and this is why up till today, many countries, even in the West African sub-region, are referred to as dark corners of rabies on the continent of Africa. Now, regarding the etiology of rabies, all the 17 virus species that are currently listed under the genus Lyssavirus, other Mononega viralis, and family Rhabdoviridae, of which the prototype is classical rabies Lyssavirus, can cause rabies. So it is not just about the classical rabies virus genotype 1 that we know. There are 16 other virus species under the genus Lyssavirus that can potentially cause rabies in both human beings and animals. And I'll be talking more about this later because that is a gap that has not yet been fully examined or researched, even in our country, Nigeria. As has been said before by one of the participants who commented, there are an estimated 60,000 annual human rabies deaths worldwide. And of these, Africa has a huge share. Africa alone has an estimated 24,000 annual human rabies deaths, and that is the confidence interval there. And these publications were drawn from publications such as Himatsuda et al. 2013 and Swift et al. 2013. The first documented cases of human rabies in Nigeria, that was in 1912, when and it was gleaned from the annual report of the southern colonies, described one case in Eket and another one in Boni in present-day Akwa Ibom and Rivers states, respectively. So these were the locations where rabies were first reported and documented. Not that prior to that time, there was no rabies. Rabies had always been in our environment here. In Yoruba land, we call it, in Hausa land, it's called Chiwo Haukan Kare, that is the mad dog disease, the disease that causes madness in dogs. In Yoruba land, we call it Arun Dibolugi. So all the local communities and languages and dialects have definitions of rabies. It is not a strange occurrence in our environment, but it was in 1912 that the disease was first reported officially in Nigeria and documented. And like I said earlier on, that was in the report of the southern colonies of the country. In 1925, the first lab-confirmed case was reported in Nigeria, and Negri bodies were demonstrated in the brain smear of a suspected rabies dog. This was according to a review that was done by Bulger and Hardy in 1960. Now, there are other Lyssaviruses, like I said, that can cause rabies, apart from the classical rabies virus genotype 1. There is the one we call the Mokola Lyssavirus. Mokola Lyssavirus is a genotype 3 rabies Lyssavirus. And it was first isolated in Nigeria in 1968 from 3 shrews. We call them Asi in Yoruba land. And these shrews, the scientific name is Crocidura species. And this was also isolated from 2 young human females, proving the zoonotic potential of Mokola virus. Mokola virus has been documented to cause disease in humans. And the first reports were in 2 young human females here in Nigeria. One of those patients died. This is according to a report by Nell et al. 2000. Now, Lagos bat virus is another virus that was first isolated here in Nigeria from the brain of a fruit bat. And the fruit bats are called, they belong to the genus Eidolon and species Helvum. So they are Eidolon helvum bats. They belong to the order Megachiroptera. These are very large fruit-eating bats. Now, spillovers of Lagos bat virus have been reported in dogs, that is spillover infections from bats, from these bats into dogs, cats, and a mongoose have been documented, but there are no known human cases yet. But that does not mean that it is not existing, because it is also possible that cases are occurring and are being misdiagnosed. This is another gap that I think is worthy of research investigations. Globally and in Nigeria, dogs are the most important rabies vectors. And up to 99% of all rabies cases in humans are traceable to bites of suspected rabies dogs. Non-bite transmissions have been reported also in scientific literature. That is, it is not only the bite of a dog that will cause rabies. There are many other ways by which rabies can be transmitted. Now, these non-bite transmissions include contamination of the skin or mucous membranes by infectious saliva or aerosols, via direct inhalation of aerosolized rabies virus, vertically from dam to fetus via placenta, as previously observed in a gravid skunk, that is in a pregnant skunk and its embryo, and indeed in a gravid cow and its fetus. A non-bite transmission could also involve infected organs that are used for transplantation surgery. So if you collect such organs from a donor who is rabies, and you transplant such organs into a healthy recipient, such a person can come down with rabies. And there have been cases of this in the scientific literature documented. Active rabies cycles in Nigeria are of two types, the urban rabies and the sylvatic type, and both have been reported extensively, but I've just picked a few of those reports. Urban rabies as reported by Olarinmoye et al. In 2015, and sylvatic cycles of rabies as reported by Ayodeji et al. As reported by Olarinmoye et al. 2015, and sylvatic types as recorded by Ayodeji et al. And Nel et al. As shown. Now, this is just an illustration of what happened. And there you see the picture of the person being attacked by a dog. And on the lower side, left-hand side of the slide, you can see bites, injuries on the forearm of a victim, of a dog bite victim. And the other slide on the right shows how the virus is inoculated into the body of a human victim through the bite of a rabid dog, and the rabies virus is shed copiously in the saliva of such an animal that is rabid. Those viruses will travel through the muscle, first of all, and then locate the neuromuscular junctions. And then at the neuromuscular junctions, they bind the nicotinic acetylcholine receptors, and from there, they move on within the axons of the nerves, in peripheral nerves, via a process that is referred to as retrograde fast axonal transport. And then the virus replicates in the major neurons of the spinal cord and local dorsal root ganglia, and rapid ascent to the brain follows. Eventually, the virus reaches the brain. There is infection of the brain neurons with neuronal dysfunction. And then later, there's centrifugal, that is outward dissemination of the virus along nerves to the salivary glands, the skin, the cornea, and other organs of the body. So that is that for the urban cycle. I mentioned the sylvatic rabies infection cycle, and this involves rabies, primarily rabies virus circulation within bat populations, because the progenitor viruses, the progenitor Lissa viruses, that is the very, very earliest forms of the Lissa viruses or rabies-causing viruses, are believed to have their very origin in bats. Now, as the rabies virus circulates in the bats, it can result in deaths of the bats, because the bats are also warm-blooded animals. However, there could be spillovers into dogs, into raccoons, and into other types of canids. And there could even be spillovers into the human population. And when this happens, of course, death is almost always the result, because rabies has a high case fatality rate of 99.9%, and it is the deadliest and most deadliest of all the known zoonoses. I wouldn't want to bog us with this, but I could share these slides with the program organizers later, so that anyone who wishes could have access to it. But it talks about the pathogenesis of rabies virus infection in the nervous system of a host. Some of these things I've already mentioned in the previous slide, but it gives us a clearer and sharper focus and presentation here so that you can actually visualize what is happening at the cellular and molecular levels and how the virus moves from the point of inoculation into the central nervous system, where it causes the greatest damage that we all see in the clinical signs that are typical of the virus. So I'll move straight on to the changes that occur in the demeanor or behavior of a rabies infected person or animal, because it is exactly the same. And the stages of rabies include the following. The first one is called the prodromal stage. This is the first stage. It lasts between 1 to 3 days, marks the appearance of the first clinical signs or symptoms that are typically vague or non-specific. Like the second moderator, first moderator mentioned that there was a case and they were not sure of what it was, and they were even carrying the victim from, they thought it was a demonic attack or something. Imagine how many people would have been exposed and the concomitant or the ripple effect of that on the population. So it is a very difficult disease to diagnose initially at the initial stages, and this makes it even deadlier. It is an indication of the successful infection of the host by rabies virus. So when you start seeing those gradual changes, it signifies that the virus has entered the body, but not only has it successfully invaded the body, but it has also established itself properly and it's replicating. It is at that stage that you start to see those changes that are typical of rabies. In humans, what are these changes? The signs are mild and non-specific, like I said, and include a slight fever, 37.8 to 38.9 degrees centigrade, pain, or an unusual itchiness in the region of the bite wound. There is sore throat. The onset of hydrophobia actually is what is seen as that sore throat. There's photophobia, coughing, and musculoskeletal pain. Stage 2, this is the acute excitative or neurologic stage. It lasts 2 to 7 days. The virus migrates through the CNS, causing progressive inflammation of the brain and spinal cord. And then you start to see things such as clinical signs such as hyperactivity, irritability, hyperesthesia, aerophobia, photophobia, lacrimation, dysphagia, hydrophobia, and drooling. The virus replication in the brain causes cranial nerve impairment. And then you start seeing clinical signs such as neurologic deficits that result in palsies, asymmetrical dilatation and constriction of the pupils, loss of corneal reflexes. The person just, when you shine light or anything, the eyes don't blink. There's facial paralysis due to paralysis of the facial nerves, and there's hoarseness in dogs. This stage is what is referred to as the classical mad dog syndrome. The animal is irritable, easily provoked, alert, restless, shows erratic movement, barks and growls unprovoked. It also attacks other animals, people, and even inanimate objects such as wire fences. As this stage progresses and replication and virus replication in the brain continues, it gets to a point when one starts to see the onset of signs such as locomotor ataxia, that is an unsteady gait, and even seizures in such affected persons or animals. And there we see a human patient, a human rabies patient, and you can see that he has been restrained, because if he is not restrained that way, the activity can be very violent. And there also is a restrained dog that is rabid. The third stage of rabies is what is referred to as the paralytic or end stage. Death occurs at this stage as a result of progressive ascending paralysis, respiratory failure, and peripheral vascular collapse. Now, the second aspect of my presentation is this: One Health action in rabies eradication. What do we need to do under the One Health canopy? And how do we need to do it in order to be able to effectively reduce the scourge of AIDS in our environment, in our country. I'm also going to be talking about the research veterinarian's perspective of these things and future research trajectories in Nigeria. In what direction should rabies research go in Nigeria? I'll be talking about that briefly. Number one, identification and tracking of the etiological agents of transmissible diseases through space and time, using not only molecular techniques, but also the analytical tools in evolutionary biology. And this includes things like phylogenetics and the molecular clock analysis. And I will talk more about that when questions come later. And then even geospatial referencing. And with the use of geospatial referencing software, you will be able to map the locations where rabies incidence is very high in the country. Number two.
Sir, I'm sorry to cut you short. I would just like to inform you that you have 10 minutes more because of time. So just to give you a
I'll be very quick. Yes, I have just two more slides.
Oh, okay.
The focus of One Health action should include the following: data audit. What do I mean by data audit? It's an exhaustive review of all the available information on rabies at any given point in time. And this, to a large extent, will involve the use of all the things I have mentioned: molecular techniques, the use of GIS software, and the use of other methods, clinical diagnosis and use of hospital records and veterinary clinic records, because this will give us a very good overview of what is happening in the country as we speak. So data audit will involve things like mapping of the dog bite cluster alarms and hotspots of rabies. Where are people most likely going to get bitten by dogs? And I carried out a study like this in Liberia using ArcGIS and SATScan, and that was in 2016. It has been reported in scientific literature, and the references will be presented at the end of this end of this presentation. You could always Google them for more information. It is also very good to analyze the trends of dog bites exposures of not only human beings, but human rabies cases and also animal rabies cases. This has also been documented. The importance of establishing trends is that it can then help you to model the occurrence of dog bite injuries and exposures that will eventually predispose people to rabies. And the use of this modeling will help you to be able to come up with actual numbers of people that will be bitten by rabies and require prophylactic interventions. I'm sorry, I can't see my screen again. Hello?
We can see your screen.
So we can still see it.
Yes.
But I can't. I'm sorry.
Okay, do you want to reshare it?
Yes, okay, maybe I should do that very quickly. I don't know why that happened. I'm sorry, this is unusual. I wonder what's happening. It says I'm sharing my screen, but I can't see my own screen. Okay, I think there are times I wish I can be more tech savvy. Let me go page. No. Aha, so I'm sorry about that. So I was talking about the analysis of trends. The first presenter said something that the federal government of Nigeria bought like 10,000 doses in 2015. If you know where the hotspots are, where human beings and people are likely to be exposed to dog bites, you can actually send those vaccines there deliberately. Because at the end of the day, what will usually happen is that we will distribute it randomly. And vaccines may end up in places where they are not actually needed much. Meanwhile, there are other places that need those vaccines critically. So when we know where the hotspots of exposure are, and we can predict the number of people that are likely to come down with rabies as a result of exposure to dog bites, rabid dog bites, we can do a lot of things and change the way, and by changing the way we do things, we can actually reduce the rabies burden in the country. Finally, determining the molecular characteristics and the phylogeny, and by phylogeny, I mean the ancestry of these lyssavirus strains that are circulating in our region, will help us to be able to know and will help us to be able to comprehensively gather information that can then be used later in the creation of vaccines that will be more effective than the imported vaccines that we are bringing into the country from Europe, from China, and from elsewhere. Because I don't have much time, I would have given us some more information on how there was a problem in China and how it caused problems later in Liberia. And this has been reported in scientific literature, precisely Epidemiology and Infection, Cambridge University Press, where I documented the first transcontinental transmission of rabies. And that rabies virus was found to have its origin in Southeast Asia, precisely China. And it made its landfall in Liberia in 2014. And that has been documented. And this was in the era before pandemics such as Ebola and the current COVID-19, which is still going on in many parts of the world. So there is a gap in knowledge in that no human cases also of Lagos bat virus infection. Remember that I said Lagos bat virus infection has not been documented in humans in Nigeria. However, it does not mean that this is not happening, because it's possible that we are seeing clinical cases of rabies and we are assuming that it is caused by rabies virus genotype 1. Meanwhile, it is another genotype or species of lyssaviruses that is causing what we are seeing. So until we can comprehensively investigate and get laboratory evidence of all cases, we may be missing all these very important details, and we will not be able to comprehensively talk about the rabies burden in Nigeria. Neither would we be able to mitigate the problem. One health interventions must be systemic, they must be multidisciplinary, and they must be intersectoral. And that is why I doff my cap, the first presenter, because of the coverage. And until human medics and veterinarians work hand in glove, we will not be able to solve the scourge or remedy the problem of rabies in Nigeria. One health interventions will include the development of maps that utilize dog bite related data. It will involve trend analysis and forecasting of dog bite and rabies cases in humans. And this is what we refer to as passive surveillance. It will also involve molecular studies. And these molecular studies will lead to updates the database of lyssavirus strains circulating at the dog-human interface in different parts of Nigeria. And this is a necessary first step in the development of locally sourced, polyvalent, safe, effective, and affordable anti-rabies vaccines that incorporate autochthonous, and by autochthonous, I mean the indigenous field strains of rabies viruses. It is noteworthy that a majority of the canine rabies vaccines and all human rabies vaccines marketed in Nigeria incorporate foreign rabies virus strains. Thanks for listening.
Thank you very much, Dr. Olarinmoye, for that wonderful presentation. It was quite exciting. Let us move on to the question and answer segments. If you have any question to ask our speaker, you can raise your hands and I'll call you, then you'd ask your question, or you can drop them in the chat box. Questions, comments, suggestions to are quite welcome to. So I'll be expecting to see some questions now. Yeah, while people are getting ready to drop their questions, I would just like to give a suggestion, because I know we have a lot of people at the top here with us. So I'd like to suggest that we use students for community engagement projects, because as a member of the International Veterinary Students Association of the Nigerian branch here, last year we came up with an idea called the 10,000 Pulse Projects, and what we planned to do was to at least vaccinate 10,000 dogs before the end of before the end of next year. And currently, we wrote to some organizations, we got funding, and very, very soon, that project would kick off and we'll start our mass vaccination program. So I would just like to implore the people at the top here that, if they can encourage students in this community engagement project, support them with funding, I believe we would be able to reach our goal of the 0 by 2030 goal. And also, if we could also include it in policy frameworks, because for example, in my faculty too, something we do is that once a student gets to the 5th year, in collaboration with the university clinic and the veterinary teaching hospital, that student would get, or a veterinary student would get a pre-exposure vaccine. So I believe if this could be included and made extensive such that it would cover all potential health workers. So I believe this could also help in curbing or eliminating the virus by 2030. So let me check the chat box for comments and questions.
Okay. Can I ask a question?
Oh, of course, ma'am. Of course, ma'am.
Okay, all right. Thank you so much, Dr. Ayodeji, for that wonderful presentation. I think the last time I have had the pathogenesis of rabies being discussed in details was 11 years ago in my veterinary school, or maybe 12 years ago. So I was very happy to see that kind of detail, just to remind us really of how much this virus, the pathogenesis, how it moves from the from the bite to the nervous system to the brain, and all of that was very interesting. And also it was interesting to see that there is a lot of new research that has been brought up since, of course, the last time some of us have been able to read, maybe get more knowledge about this disease. Thank you so much. So I have a question, which is on the research community. I know that based on what I know, there are activities that are being done or that are being planned with regards to rabies elimination, especially with the new global strategic plan to eliminate rabies. And however, I still see a lot of gap with the engagement of the research community, and research meaning the people who are, of course, people who are involved in doing research on rabies. I don't see many of these stakeholders who are represented in some of these meetings, some of these discussions. And I want to ask that, if you think this is true, I mean, this is my opinion, so I could be wrong, but if you think that this is true, what do you think may be the reason, and how can we best engage the research community, particularly with regards to rabies, to be more involved in the movement that is building for rabies? And also because we need research to be much more, we don't like that, or I personally don't like that research is being done for research sake, but we don't actually be implemented to make social impacts. Why the reason why there should be research in the first place. So how can we best engage research community to be more involved in some of these events and programs, and what do you think their role would be best for supporting this movement for rabies elimination? Thank you.
Well, I'll start by saying thank you very much, because your questions are very incisive and they address the problem as we speak. And two, that I believe that your group got it very right when you decided to organize this year's World Rabies Day celebration under the One Health canopy. Because when I was in school, One Health wasn't as much spoken of as it is currently. And this has been a challenge because traditionally we were schooled, and I mean both the medical practitioners and the veterinarians, We were schooled to operate in our individual silos. But it got to a point when, even at the World Health Body level, there was a consensus on the fact that the most effective and the most efficient, and when I say efficient, cost-saving interventions, and the most impactful interventions will require the collaboration of subject matter specialists on every possible scale. Not only the human medics, but also the veterinarians, the geographers, because I mentioned the use of GIS technology when I was doing, in one of my papers that I reported here. And I've also used it extensively, even in other research engagements. And I'm not a geographer, but I've had to interface with those subject matter specialists, and they brought value to what I was about to do at that time. And I have a lot of friends also in the medical field that I network with very, very closely. Yes, again, there is a problem in that in the local environment, much of those in whose hands the information that can change and drive and cause change to happen, many of them are not engaged as actively as they should. And that is the problem. But I am very happy that the first presenter from the Ministry of Health has that mindset, because when I heard her talking about zoonosis, I said, aha, and by the grace of God, if we can get more individuals like her, the ripple effect of what they do will eventually change the way we go about things. Finally, is the fact that funding is a big challenge. Get a typical researcher. He will give you 10 research topics, just like that. But the problem is how to carry out that research if the funds are not there. I would not have been able to do my research if I was not sponsored by my university here, which is Babcock University. For the first 4 years, they paid my way. And for that, I will be eternally grateful, because I cannot imagine how I would have been able to do what I did during that period. I also was able to benefit from the research from the research funds of my mentor, who got a grant under the CCPs. And by my mentor, I will always talk about him wherever I am. That's Dr. Babashola Olugasa. He mentored me, he supervised my PhD, and I benefited directly from his own funds. In fact, he paid my way to Liberia, and that is on record. Apart from that, your ability to network with people in other clients, that is in other countries and research institutes and laboratories, would help you to do the needful. Because if you continue to wait, you have all the ideas, but you continue to wait for help from within the local environment, it may never come. So all you have to do, like I did at one point in time, because I'm a very practical person and I want to show what is possible. I got on my system and I started chatting, writing emails to people in laboratories. I wrote Pasteur Institute in France. I wrote the Biomedical Primate Research Institute in the Netherlands, in Rijswijk, Netherlands. I wrote people in the CDC in Atlanta. I wrote. I wrote Saudi Arabia. I wrote a laboratory in Saudi Arabia. So your help can come from any direction. All you need to do is to be a bit more proactive and assertive. The help may just be around the corner. And without trying, you may never get it. So the problem we have in Nigeria is that there is a systemic lethargy. Generally, the system is slow recognizing and integrating the subject matter specialists in research programs and projects. And this is why we are where we are right now. There's so much we can do. Imagine in just 2 or 3 slides, I gave you about 5 or 6 or 7 research topics. And if there are any masters or PhD students here, These are fertile areas that you can mine. They are just like gold mines, and you will get lots of international recognition if you can break those if you can answer those unanswered, currently unknown or unanswered problems. So there's a lot. We have a lot of potential here, but until the ministries and the non-governmental organizations and so on come together under the One Health canopy, we will not be able to solve the problem of rabies. And rabies is just one problem. There are so many other diseases that are neglected, that need our attention, and that are daily killing our people. Thank you.